Okay, I think we will get started. We are just 6 o'clock on the dot. Welcome back and Happy New Year, I guess, to everyone. This is the Canadian Concussion Center's webinar series, which is sponsored by LIUNA, the Laborers International Union of North America. And my name is Leslie Rattan. I'm really pleased to be moderating our ongoing series, which was developed for individuals that have suffered concussions, their caregivers, as well as healthcare providers. And we're resuming for the 2026 year. And our sessions will be running again every other Tuesday evening at this time. And if you've been with us before, you know that our sessions focus on various aspects of concussion. And we hear from an expert speaker during the first half, and then you get a chance to get your questions answered during the second half of the session. So just to orient you, if you look to the bottom of your screen, if you sort of move your cursor, you'll see that there's a Q&A box. That is where you should enter any questions that you have for our speaker tonight. If you're having any technical difficulties, please enter those into the chat. Also, thanks to Christian, he has put the link into our website and to our previous webinars. So if you haven't checked that out, we record and archive all of our webinars. So you can go back to watch any, if you're not able to stay for the duration or are interested in some of our ones that have already run. Just before proceeding any further, we always like to acknowledge the Indigenous peoples of all the lands that we are on today. Even as we're meeting virtually, it's important to recognize the lands we each call home and reaffirm our commitment to improving relationships and understanding with local Indigenous peoples. From coast to coast, we honor the ancestral and unceded territory of all the Inuit, Métis, and First Nations people that call this land home. And we are going to run a short poll. We always do this just to get a sense of who is in our audience. So I'll just give Christian a second to pull that up. Perfect. Excellent. Thanks so much. So for this evening's session, I'm really pleased to welcome back Dr. Carmela Tartaglia. She's going to be presenting concussion in older adults. Dr. Tartaglia is a professor at the University of Toronto and cognitive behavioral neurologist at the UHN Memory Clinic, where she sees patients with neurodegenerative diseases and persistent symptoms of concussion. She is a scientist at the Tan Center for Research in Neurodegenerative Diseases, where she uses a multimodal approach for biomarker discovery to facilitate early detection of neurodegenerative diseases and diagnosis of persistent symptoms of concussion. She also holds the Marion and Gerald Soloway Chair in Brain Injury and Concussion Research. And with that, I'm going to turn it over to Dr. Tartaglia.
Hi, everybody. I'm going to share my screen and hopefully that you guys can see this. Hopefully, we can assume.
Yes, looks good.
All right, thank you. All right, so yes, welcome and Happy New Year to everybody. I think I can still say that, but probably the last week. So I'm going to talk tonight about concussions in the elderly and those with neurodegenerative diseases. Often a group of people that are overlooked, and we'll talk a little bit about why and what can happen in these people. So we'll identify some characteristics that are unique to the elderly and describe how these characteristics can influence diagnosis and then maybe some unique clinical social resources. So traumatic brain injury in older individuals is actually very, very common. The data out there shows that the people who are in the older age groups, so anybody who are, above 65, that there's actually an increasing amount of traumatic brain injury in these older individuals, and that there are significantly a significant portion of them that get hospitalized, and that unfortunately, there's a great number of deaths in people who have traumatic brain injury when they're older. Um, so these are, large studies that have looked at that. And so there seems to be when, we're evaluating the frequency of these, is that they seem to be on the rise. It's not really that clear on why that is. Maybe with more older people being more active, more people living into older ages, but the data consistently shows that there's an increasing amount and very by large numbers, like 61%, 69% increases of people being seen for traumatic brain injury. And this is of all severities. But as you probably know, 80% of all traumatic brain injury is actually concussion. And, we looked in Ontario too, and this was a really nice study that came out a few years ago. And basically, again, showing that obviously the highest incidence is in the very, very, very young, but you can see that again in the over 80, it starts to rise again. And the majority of the oldest old with traumatic brain injury happen to be female and white. This was a study published a few years ago. And the importance of looking at this is to try to understand, what population is really affected, why they're being affected, what's bringing them to have a concussion. In terms of causes of traumatic brain injury in the elderly, so falls are a really, really common cause. Unfortunately, these falls can also happen in the hospital. Motor vehicle accidents, maybe not that well known that 70-year-olds have a higher accident rate per kilometer than any other age group except for young male drivers. Some of these can be related to age-related changes in cognitive functioning or motor function. Suicide is actually a very frequent cause of injury in the older group. And then obviously elder abuse, just like in any other populations. So it's actually important to think about the mechanism in older people because when we think of somebody who's gotten a traumatic brain injury from a fall, we worry more about these bleeds, whereas from motor vehicle accident, and this across all ages, we worry more about diffuse axonal injury. And the actual distribution of mild, moderate, and severe is unknown, but again, the studies suggest that it's similar across all ages. So, how about assessing patients with, who are older, who might have had a mild traumatic brain injury? So, it's sometimes much more difficult to assess people because there are age-related issues such as variable baseline cognitive function, impaired memory that might have not been detected prior to the injury. As well, people can have comorbid diseases, so more than one disease. Obviously, the older we are, the more likely we are to have more than one disease. We're sometimes older people are taking medications that can affect their mental status. And of course, there could be an interaction of all these medical conditions, the medications, the fall or premorbid cognitive difficulties. And so it is actually more difficult to make a diagnosis. And it's always important to remember that the only way to make a diagnosis of concussion is a clinical way, right? So somebody has an event and then they come and tell you that they developed some symptoms after this event. And then, you diagnose them with a concussion. Well, what about if people aren't telling you because they've forgotten that an event occurred? They can't report the symptoms very easily, or maybe they don't actually even want to tell you because they're afraid that there'll be some consequences to their independence. So, people who are older are at higher risk of falling, and with repetitive falls, they're also at higher risk of repetitive head injury. When people are older, there's a risk of delayed in bleeding into the brain, especially a lot of older people are using blood thinners. And there's also an increased risk of bleed because the brain is more shrunken when you're older. And that's just natural shrinkage of the brain, and it's probably starts when you're 30s, 40s, and just gets is obviously greater when you're older. So if you look at, the brain on the right, you can see a lot of black there in that space, but that brain, when it was younger, probably looked like the one on the left, where there's actually very little black space, right? That's what your brain should look like when you're in your 20s and 30s. And when you're in your 70s and 80s, there's a lot more space. And so there's actually a lot more space that can be filled up by blood before you actually, are like notice. And so sometimes people can end up with a huge amount of a bleed, like a very large bleed when they're older. And so in older folks, actually, there's a lot of TBIs that are missed. Like I said, they can be not reported because they're forgotten. There's a fear of being prescribed a walking aid or institutionalization. Sometimes people, if you fall often, it's not safe to stay in your home. So, people are afraid of that. You need to know if the memory was impaired before, because obviously, if people can't remember that something has happened, then maybe they're not even telling you. They sometimes people just show up with unexplained bruises, and they can't actually even tell you how they got these bruises. There can be gaps in the memory. And of course, like I said before, some of the medications that often people are taking to help one thing as a side effect can, worsen your memory or cause low blood pressure, which can, obviously promote falling. You can get medications that also cause what we call Parkinsonism, this slowness, this stiffness. And, a lot of times patients aren't being referred. I had looked a few years ago and, in over 1,000 referrals, less than 1% of people were over the age of 65, which when you think about it, doesn't really make sense because, we have a lot of older people in our society. We have a lot of activities that can lead to concussion because, patients fall and they have motor vehicle accidents and kinds of things happen. And so, how could it be that they're not suffering from concussion? The numbers are increasing, however, but they're still quite small compared to younger people. We actually sent out a survey to physicians a few years ago trying to understand why are people not being referred. And so we sent it to 1,400 people, and 141 physicians replied. Most of them were neurologists, but there were some geriatricians there. And we asked them questions about, well, do you ask your patients if they've had a fall? Do you ask them about concussion symptoms? And unfortunately, we found that over 70% of physicians actually never ask about a history of falls. And what was even more surprising was that over 96% of the physicians don't inquire about any concussion symptoms, even when the patients or the care partners mention a fall. So, uh, was, something a bit unexpected because if you are younger and you go to your doctor and you tell them that you've had some accident or, oftentimes, you probably are going there to complain about some symptom that has developed after the accident. And so you are diagnosed with a concussion. But, even though older patients have events that you would think they're at risk of hitting their heads, they're at risk of having a concussion. It's actually overlooked, and this is probably one of the reasons that we're not getting that many referrals because they actually aren't diagnosed. So as I mentioned, pre-existing medical conditions have been associated with worse outcomes after traumatic brain injury. And, of course, these are common in older adults. And, we all know that a past history of a traumatic brain injury is a risk factor for another brain injury. So, of course, that, makes things even worse. Then some of the common things that we see in older adults, like cerebrovascular disease or depression or difficulty with activities of daily living, are all risk factors for traumatic brain injury. And older adults with traumatic brain injury are at higher risk of morbidity and mortality. They have slower recovery trajectories. They do actually, there is some evidence that they do worse functionally, cognitively, and psychosocially when compared to younger people. And if they're hospitalized, they actually do end up requiring extended hospitalizations and more, and you know, get discharged with more severe disability and more functional dependence. So, there's a real there was a lack of uh, data on how to actually assess people for older adults. And so there are now living concussion guidelines for older adults that are published as part of the guidelines, but these are specific. And I think one of the most important things is that we you know, with the data available, we felt that it was very important that concussion should be suspected in all older persons presenting with a fall or another mechanism of injury that could plausibly cause a concussion. So, not to wait for people to tell you that they've had a concussion, but really to assume that they have had one. And if an older adult presents with new onset cognitive impairment, a concussion should be considered within the differential. When older people have a problem and then they develop some agitation or there's a change to their cognitive function, sometimes we worry about a urinary tract infection or some other infection. But you could imagine if you hit your head, or not even hit your head, but you hit your body hard enough to end up with a concussion. Well, of course, one could imagine that, you could end up with some, more cognitive impairment. And for older persons presenting to the emergency departments after a concussion, the neuroimaging rules that we apply, which is the Canadian CT head rule, should also be applied to them. If they're, however, taking anticoagulation, like so blood thinners, they need to get neuroimaging immediately after concussion. For people who are over the age of or 65 or older, in routine in-hospital observation periods or repeat CT scan are not recommended. And older people that are diagnosed with concussion should have their symptoms managed, just like any other age group. And for older persons diagnosed with concussion and also having geriatric health issues, it was recommended that they be referred to a geriatric assessment program. What about cognitive consequences of TBI in older adults? Well, as most people who have suffered a concussion know, it's very common for people to complain about changes in cognition. Oftentimes, people who had a concussion will tell you that their processing speed isn't the same, that they can't concentrate as well, that their memory isn't as good, that they're having more language problems. Well, obviously, one could imagine that the same would apply to an older person and that there, could be increasing impairment with increasing severity, and that there has been slower cognitive recovery noted in older people, and that sometimes the cognitive outcomes are worse compared to younger, although this is inconsistent. And of course, your pre-morbid condition can affect outcomes, so it's important to know the baseline. What about neuropsychiatric symptoms? So, same thing. The prevalence of psychiatric disorders after concussion are very, very high. Depression, anxiety are very common. The more concussions you have, the higher the risk. Of course, you can have more than one psychiatric symptom. Post-traumatic stress disorder symptoms can overlap. You can obviously have comorbid conditions, so with substance abuse. And if you had a psychiatric condition before, it can get worse. So similarly, when an older person has a concussion, again, neuropsychiatric symptoms can be quite common, and the most common include depression, anxiety, irritability. And that when you compare older adults with traumatic brain injury, it's significantly higher for them to have depression than, an older community dwelling person who's not had any traumatic brain injury. TBI in older adults was associated in one study with an 11% increase of new onset depression and a 50% increase risk of new onset post-traumatic stress disorder. And so it's really important to screen for depression after traumatic brain injury in an older adult, just like it would be in a younger person. And how about treating people? Well, we treat them the same way we treat younger people. We target all the symptoms. So if they have post-traumatic headache, if they have vertigo, sleep issues, which are, obviously common in older people, we treat that. Obstructive sleep apnea is common after a concussion. It's also common in older people. So people need to be assessed for sleep issues. Neuropsychiatric symptoms are affected by physical symptoms, so you need to address both. And of course, part of the treatment of post-concussion symptoms in older people is really to think about preventing. So, assess why the concussion happened. Was it a fall? Just, a trip and a fall, like it can happen to anybody, or is it because, they're having increasing difficulty walking and maybe you should be sending them for a walk, a gait assessment, and do they need a walking aid? Is something about their home unsafe? So maybe they need an occupational therapist to go in and assess them. Getting in and out of bathtubs sometimes can get more difficult when you're older. Did that contribute to their fall? Motor vehicle collisions, as I've said, it can be quite common in older people. So is there something about their cognition, their motor function that put them at risk of motor vehicle accident? And are they at risk, of another one? Fall prevention programs can be very important to teach people about what to look out for so that they can, prevent further another fall. And this idea came out a few years ago, but I think now is very well established that past history of concussion is a risk factor for neurodegenerative diseases. So, remote head trauma has been associated with chronic traumatic encephalopathy. This is, the disease that has been found in these professional athletes, which is very, very rare and is really linked to these repetitive head injury for years. But head injury has been associated with Alzheimer's disease, Parkinson's disease, ALS, and other ones. And so, of course, the aging population is concerned because, most of us have had, some event in our lives that could be associated with a concussion. As well, older people, concussions weren't really recognized. And so many of them have had more than one event. And many older people are complaining about memory and, cognitive function. So of course, it is important to consider that. The 14 dementia risk factors that have been named, head injury is number 5 and is there. And I always tell my patients, well, what has already happened to you cannot change. But if you look, there's 13 other risk factors there that you could possibly do something about so that you could mitigate the risk that you can't do anything about. So physical inactivity is really bad for the brain. So we want people to exercise. That's good for the brain. That's good for good to ward off and to delay the onset of neurodegenerative diseases, and has been associated with good recovery from concussion. And so obviously we promote people to engage in more physical activity. Obviously, stop smoking, reduce alcohol to none or less than two per week, making sure that people are social, that they're learning things, that they have their blood pressure and their diabetes well controlled, that their depression is well controlled, that they're hearing properly, that their vision is good, and that their cholesterol is good. So there's many risk factors that people can you know, incorporate healthy lifestyles so that we could, promote that brain health, even if you've had a head injury. And so, I think it's the fact that a head injury is a risk factor for dementia. Obviously, we can't forget the fact that you could already have dementia and get a concussion. And so, This is a particularly vulnerable group because concussion in these people is often undiagnosed. So patients can't recall, they're afraid to report, and it could be associated with a sudden deterioration. So sometimes we ask family members to look out for, is there signs that the person has fallen? Are there new bruises? And the thing is that it's important to remember that if you have untreated symptoms like headache or dizziness or like vertigo, or your sleep is bad, or your mood, you become more irritable. Well, of course, that could be associated with some new behavioral issues or worsening of behavioral issues. And so it is important to at least consider that the person has had some event that could be that could have caused a concussion. And of course, when concussions aren't being diagnosed, then there become a risk for even more concussions. And so, to summarize, personalized medicine is important when you're thinking about concussions. You need to consider the person, their circumstances, and the mechanism of injury. There are special populations. So, what works in somebody who's 20, 30 years old, who can, tell you about what's happened, doesn't necessarily work in some of the older people, some people who have pre-existing cognitive impairment, and some of them don't even have that. They're just they have a fear of reporting, or they're embarrassed of reporting. And so there are some global vulnerability factors for persisting symptoms in older people that need to be considered. And of course, previous concussions, can be a risk factor for dementia, but as well, if somebody's already got some problems with cognition, the concussion can make things worse. And that there are many risk factors in the elderly that can put people at risk of concussions. Here are a few resources for Parachute's got some really nice resources about adult falls. We have had some previous uh, webinars on older adults. And thank you for listening. So I will stop sharing and
Great. Thank you so much, Dr. Tartaglia. That was excellent. I'm just going to go to the questions. So for those of you watching, if you have any questions that you would like answered, please put those into the Q&A. Okay, here we go. So our parents can be stubborn, and there's an urgency to get them to the doctor, hospital following a fall. Reality is some may refuse to go even after they have multiple falls. What should people be on the lookout for?
yeah, that is a great question, and a real world question, because it's true that, sometimes people don't have the insight to recognize what's happened. So I honestly, I tell people look out for things where, if there's a sudden change in somebody's function, a sudden change in cognitive function, a sudden change in somebody's mood, then you can, worry that something has happened. I tell people like look for bruises, look for, of course, older people sometimes are more prone to getting bruises, but if you find that somebody's like scratched their knees and or their elbows and or has some scratch on their face, and you're like, well, how did that come about? So a lot of times I tell families you have to be a little bit of a detective, and getting people to the doctors. I think it is sometimes quite difficult. If somebody has had a fall in the home, I think one thing to make sure is that there's been an occupational therapist in to ensure the house is safe. Like, are there the grab bars where they're supposed to be? Are the carpets that could put people at increased risk of falls? Because that actually is one
Mhm.
of the most common reasons people end up with a concussion, is because they fall in their own home. People love these like low coffee tables, which can be a real menace. Bathrooms that have these rugs that don't stay, in one place. So occupational therapists are really good for that, and the family doctors could send somebody in, even if, the person doesn't, you like necessarily go into the doctor. So to alert somebody about that.
Hmm. For sure. Okay, thank you. I had my first concussion in my late 50s and still suffer from headaches daily. I'm now in my mid 60s. Could it be that aging is impairing my ability to recover?
Yeah, that's a great question. But it's a difficult question to answer because, post-traumatic headaches, even in young people, can be, and, I have to say that in your 50s and 60s, you're still quite young, can be quite resistant to treatment. And so sometimes there actually are a number of medications that we try to prevent headaches. And there actually are a new family of medications. And so I would say if you haven't seen a headache specialist, you should, because there are a lot of new treatments. Headache is one of the most common afflictions on the planet and is and there are many people who have refractory headaches, and sometimes post-traumatic headaches are refractory. And so we have had a little bit of luck with some of these new agents. So you shouldn't give up unless you try those.
Great. Okay, thank you. Would you do imaging for a mild concussion?
Yeah, I have a problem with calling things mild or moderate or severe because concussions have no biomarkers. So, obviously, if somebody's had a major injury that's caused, a prolonged period of, loss of consciousness or prolonged post-traumatic amnesia, you can think, well, maybe that's more significant. So I used to order a lot more imaging, but I have to say that after a few hundred scans of never finding anything, I don't order them so much, and I actually reserve them now for people who don't get better, who have kind of atypical features. So I sometimes see older people who they had a concussion, their headaches get better, everything is getting better, but their cognitive function is not getting better. It's either getting worse or
Hmm.
it stays the same. Those people I image because I am looking for something else. So we don't image everybody. Like a CT scan is actually useless for that. You need an MRI, and the wait time is so long for some people that they're not even part of my clinic anymore by the time they're getting their MRIs.
Yeah,
Yeah,
yeah.
we look for like kind of red flags, let's say.
Great. Okay, thank you. On the biomarker front, apparently there was a news item today talking about a startup with the University of Waterloo, and they've developed a way to test for concussions using a simple saliva test. If this has been found to be valid, can't this be used with any age, not just young athletes?
Yeah, I agree. The problem with biomarkers, and we've been looking for them for years, is that they're very difficult to validate. So, oftentimes people will look in a few people and they find a difference, but then when they start to, do the real world thing, right, where you bring it to a place where it could be, different people have different problems, and then the biomarkers always fail. And that's the issue. So we really are, uh, as of today, we don't have biomarkers for detecting concussion. We have some biomarkers that can detect more severe brain injury, which obviously is very important. But for concussion, we don't have anything that works, really well. And I think one of the things that you always want to be careful about is that the tests have to be sensitive and specific, right? Like because you don't want to be, you know, only picking out like very severe concussions or that, maybe are have some kind of feature, and then the other people get told they don't have a concussion because the test is negative in them. So we keep our minds open to every test possible. So, saliva tests, there's, a few of them out there that people are trying, eye tracking tests, blood tests, I think imaging. So I think we have to keep an open mind, and a concussion test would be welcome in every age group.
Great, thank you. What causes obstructive sleep apnea to start or increase after a concussion? What systems are impacted that cause it?
Yeah, so that's a great question. So there are alterations in sleep after a concussion, but it's not evident, that they are related to sleep apnea. One of the things that causes sleep apnea actually is, changes in weight. And so having a higher body mass index can increase your risk of sleep apnea. What we see after concussion is sometimes people end up with so many symptoms that they really change their lifestyle. They exercise much less. They end up, some people end up taking medications that can sometimes make them gain weight, eat more. Their mood can go down, which can be associated with eating more. So one of the reasons that we often see sleep apnea is that people gain weight after a concussion. And that I would say is the most common reason that I've seen sleep apnea. Sleep changes, however, those are related to the concussion. And that's just, part of it is I think the what does a concussion come from? And we think that there's some rotational force that can happen around the brainstem, and the brainstem is the part of your brain that is important for sleep architecture, for the sleep neurotransmitters, the sleep chemicals. And so that's probably one of the reasons that the sleep changes, but that is different than obstructive sleep apnea. That's a specific disease.
Yeah, okay, great. Jim is asking, this is more on the nutrition front. How effective is keto or the ketogenic diet, I'm assuming, in treating TBI or concussion? What are the limitations in treating with keto?
Yeah, I mean, keto is not something I use for treatment. We really in our clinic we take a symptom-based approach. So ketogenic diets have, some evidence in, severe epilepsies. But I don't know that, there's very much evidence for using them in traumatic brain injury. Um, in in some of the epilepsies where we use ketogenic diets, they are people who have severe developmental disorders, and so their seizure frequency is so high that any of the negative impact of a ketogenic diet, we choose to bear because the benefits of reducing the seizure frequency, and somebody could be having like 100 seizures a day, is worth it. I'm not sure I would be using a ketogenic diet if I had a concussion, because there are side effects that I am not sure I would be willing to tolerate for, concussion. Yeah.
Great, thank you. Um, Someone's saying so difficulty dealing with a parent. My mom takes questions personally and is dismissive. What to do? I guess this is in the context if she's fallen and
Yeah, it's a really difficult area to navigate. One of the problems that we see with, not just concussion, but, older people who have cognitive impairment is that they sometimes don't have the insight that they used to have. It's important to remember that insight, judgment, they live in your brain, right? And as your brain changes in one area, like let's say memory or processing or, it could be language, well, doesn't mean insight and judgment are not going to change. And so sometimes we do see that, you know, the way the person would have reacted like 10 years ago is very different. And I think sometimes, people can have good relationships with that person's family doctor. And sometimes the person has a good relationship with the family doctor. So to try to engage them, to alert them that maybe something has changed, but it's a, it's not, there's no easy answer. We spend all our days trying to find ways to convince people of something sometimes that is not evident to them. And I don't think there's an easy
No,
solution to that.
can be very challenging for sure.
Yeah.
We have a question about diffuse axonal injury. And I'm not sure if I totally understand this. And also, how can we change that? It sounds like their parent had a fall, went to the hospital, and it sounds like they may have been diagnosed with a concussion. But so I'm not sure. I guess maybe if you can explain diffuse axonal injury.
Yeah, so diffuse axonal injury is really something that we think of as more severe than a concussion, although there may be a mild form. So diffuse axonal injury is, our brains are made up of the white matter, which is the inside part, and then the cortex, the outside part, the gray matter. When people have severe or moderate traumatic brain injury, they often have what we call diffuse axonal injury. The injury of the axons, which are the connections between different parts of the brain, are very significant and well, diffuse. That means they happen in many areas of the brain. In mild traumatic brain injury or concussion, the evidence that that occurs is actually much less, but there may be some. But oftentimes, when people die, after having had a concussion, but not from the concussion, let's say from, a heart attack, we don't see that much, we don't see real evidence of diffuse axonal injury. But older people, because of all the shrinkage of the brain, they actually, for the same event that would happen in a younger person, sometimes they are at higher risk for having a more severe injury. And so in them, a fall could lead to diffuse axonal injury, and maybe that same fall in a younger person could lead to a concussion. So that's what, we mean. And the same thing about the bleed, because there's a lot more space in the brain is shrunken. Sometimes a fall will allow, like, we have like little um, blood vessels that connect from the skull to the brain, and they can actually tear. And so older people tend to be at higher risk of bleeding around the brain, which can end up squishing the brain, which is very dangerous. So it's just a matter of the changes that occur in the brain of an older person.
Great, thank you. Gloria has a couple of questions. She's asking, she said, very useful webinar. Does having brain surgery, sounds like successful brain surgery, is that deemed as a brain injury?
So, that's a great question. I think, it really depends because on the one hand, you think anything that goes through the brain, right? Like, let's say, an electrode goes through the brain. Sometimes we do deep brain stimulation for something, or we put a shunt in the brain to, like for people who have normal pressure hydrocephalus, so this other disease. But it has to injure the brain to get where it goes, where it has to go. So, it's like a cost benefit ratio, right? Like, are you getting the benefit? And the cost is that the whatever it is has to go through the brain. So, brain surgery, in a way, it is an injury in the sense of, parts of the brain sometimes have to be cut out, especially if somebody has a brain tumor that has to be removed, if a shunt has to be put in or something. So there is some, it's like if you think about, somebody having to put a drain into your abdomen to be able to, relieve your abdomen if, let's say, there's some fluid there that needs to be removed. Well, of course, the the drain that's going through the skin, the muscles, the layers is going to injure it, right? But the benefit, because it's removing all that fluid, is greater than the injury. So, yes, I would say that you would call surgery an injury to the brain. It's just usually an injury that, results in a benefit.
Hmm. Yeah, makes sense. And she's also saying had a nasty fall, had to go to the ER several days after the fall with severe headaches. There was a great ER doc who did a CT scan. There was nothing on the CT scan, but diagnosed her with a concussion and recommended several weeks of rest. My family doctor has not taken an interest in my fall injury. Should I be pushing for another CT scan?
So I don't think another CT scan would be helpful unless they saw a bleed, right? So the only time we would repeat the CT is, let's say you had a bleed and of course you want to make sure the bleed is going away, and so maybe a month or two later we would repeat the CT. Otherwise, no, we would not. In terms of the recommendations, we would only recommend rest for the first 24, 48 hours, right? After that, we really want people to be active, safely active, but doing low impact exercise, participating in activities, being social. We don't want
Mhm.
people to rest after that. And so I think, you really want to just, um, take stock of like what symptoms you still have, and maybe, get those specific symptoms addressed by your family doctor or some other physician or nurse practitioner.
Mhm. And there's a similar kind of question. If you're not getting better, they're asking if, you're not getting better after 5 months, should you have some imaging done?
Yeah, I think, we don't do it because a person's not getting better after 5 months. Um, you know, Somebody not getting better after 5 months, it may be just because they actually aren't being treated for the symptoms. So,
Mhm.
somebody has post-traumatic headache for 5 months. I hope you're on some medication to prevent headaches. And if your mood is not great after 5 months, that is being addressed. If your sleep is bad, really depending, like, do you have vertigo? Should you be assessed for, vestibular physiotherapy? So, uh, actually, not being better after 5 months has many reasons, and most of them have nothing to do with requiring imaging.
Great, thank you. Mike is asking, what therapy is proven to be effective in the treatment of a concussion?
Yeah. So I think it's important to think about what is a concussion. A concussion is an injury to the brain, a mild brain injury. And we have no treatment for the brain injury related to the concussion. What we actually have really good treatments for, though, are the post-concussion symptoms. So concussion happens. That's basically the jiggle of the brain, right? That is severe enough that gives you things like post-traumatic headache, post-traumatic dizziness, post-traumatic sleep problems, mood making you more irritable, giving anxiety. So those are the symptoms that need to be treated, and we actually have very good treatments for those symptoms.
Great, thank you. After a diagnosed concussion, I'm experiencing blurred vision. It's only been a few months and other symptoms are clearing, but not the vision issue. Is there any data on vision recovery? I'm in my mid 60s.
Yeah, so I think, if your vision is still an issue, one and all other symptoms are recovered, so you don't have any headaches, you're don't have any vertigo, then probably seeing a neuro-ophthalmologist would be worthwhile. When, it really depends on what the vision symptom is, right? Like, is the blurred vision, do you mean double vision? And then, we would make sure the cranial nerves of the eyes are working okay. Is it that, sometimes people complain about vision, but actually it's a vestibular problem, so an inner ear problem that's giving them the vision because they feel like they're eyes are not, steady. So I would say that probably if you're a few months out and you're saying everything else has pretty much resolved, then probably would be a good thing to get better assessment of your get an ophthalmological assessment. So usually neuro-ophthalmology are good for that.
Hmm. And we do have a webinar that goes into more detail on visual issues that you can access on the website. Um, okay, the next question, I think they're asking, how do you go from a concussion to post-concussion syndrome?
Right. So post-concussion syndrome actually we is a term we try not to use anymore. And that's because this is, when you think of all the post-concussion symptoms that occur, there is no syndrome, like a specific syndrome. So usually when we diagnose a syndrome, it's because, you have these symptoms, they meet the criteria. So right now we call this persisting symptoms of concussion or prolonged symptoms of concussion or prolonged concussion symptoms, some variation on that theme. And really, the concussion is the event that, the mild traumatic brain injury that occurred. The symptoms that happen after that are all post-concussion. Now, we allow post-concussion symptoms to last about 2 weeks. And afterwards, we expect that you should get better. So by 1 month, if you aren't better and you're an adult, because kids, kids are given 1 month. Adults are actually given 2 weeks, but we usually wait from, 2 weeks to 1 month, give you a little bit of leeway. And then afterwards, we say you have persisting symptoms of concussion. And if you had a concussion a few years ago, you know that we used to wait 3 months to say that you had persisting symptoms of concussion. But what we realize is that actually most people get better in 2 weeks. And if they're not better by 2 weeks, we need to start thinking about treating those symptoms because, the likelihood of them having more persisting symptoms goes up. And so that's, why that timeline has changed. And so we, at 2 weeks to 1 month, we start saying you have persisting symptoms of concussion. Probably we need to start addressing those symptoms, whether they be headache or, vertigo or sleep disorders or mood or whatever it is. Yeah.
Great, thank you. Brian is asking, sort of back to the diffuse axonal injury, are there any tests to diagnose?
Diffuse X.
Uh, yeah, any
Not
imaging? Yeah.
Yeah, not really. Although one, when we think about it, like so MRI has some really good sequences that can look at the white matter. And so there are sequences that are supposed to be much more, let's say, sensitive to diffuse axonal injury. I would say that today, most of these MRI sequences are pretty good at a group level and not so good at the single person level, which
Mm.
you probably can imagine is a big problem because you don't care about the group level, right? Like if I take your blood and I try to test you for diabetes, what do you care about the group level? You care about do you have diabetes or you don't have diabetes? So we don't have that test for brains. Of course, if you have significant brain injury, like moderate or severe, sometimes we see um, what we call lesions. We can see bleeding in the corpus callosum, so we can see hemorrhage in certain parts of the brain. So obviously, that is a moderate to severe brain injury where we can actually see it. You know, if there is hemorrhage, we can see that. Sometimes there's like shearing of axons, so it's so severe that we call it shearing, and that sometimes can also be seen. But it's not consistent. It's not used as a test for that. But yeah, I think as we get better and better with imaging, there will be a day where we will be able to definitively say, yes, you have had diffuse axonal injury. It's in this area. Um, and
Hmm.
no, you have not. Yeah.
Okay, great. In the context of a concussion from a near life or death experience, like being hit by a car, for the emotional regulation issues after a concussion, is there a better medication for the emotional lability, anxiety, depression, PTSD? Neuropsych recommended sertraline, but neuropsychiatrist sees better results with Lexapro. Do you see better results with your patients in either?
Yeah, I think that's a great question. And, um, some like when you think of some of these medications, they're very similar, right? Because they have similar, like they're from a similar family. So, sertraline is a medication that has a good profile for anxiety as well as depression. So when people have a significant amount of anxiety plus depression, it's something that I use. But and it can work for post-traumatic stress disorder. But some people have had, better experience with different medications. So some of it is, what we call the art of medicine, which is that we do feel, we have experience, we give it to people, we get reports that things have, improved. So that's a lot of it is based on our experience. But I think in terms of when there's an anxiety component, there is some literature out there to say that sertraline works a little bit better than some of the other medications that are in the same family. But, we're all different.
Mhm.
Maybe, something that people may or may not know, there's something called pharmacogenomics, which is, like we're all genetically different, and sometimes there's certain medications that are better for one than the other. So, it's something to discuss.
Hmm.
Those are
Great.
very similar medications. Yeah.
Okay. All right. We'll just do a couple more. Geraldine this is more with regard to returning to work. When I saw a neurologist 1 month after the injury, they told me to go back to work. So she's sounding surprised by that. So wondering what your comments are on that.
Yeah, well, I would say, that person has read the latest literature, and the latest literature says that going back to work is actually really good for recovery. Of course, sometimes people need to go back with accommodations, people need to go back, to a safe environment. But yes, going back to work is actually encouraged, and we don't want people to stay home after concussions. Yeah. So I
Okay.
understand that.
Okay. And let's finally, Sheila's asking, could you comment on orthostatic intolerance after concussion from almost 2 years ago? Dizziness, rapid heartbeat, nausea, blood pressure that goes up and down by 20 points in minutes with standing, etc., but good blood pressure the rest of the time, and what she should do about it.
Yeah, so orthostatic hypotension is exactly that. It means, your blood pressure could be fine at rest, but then when you go from sitting to standing or lying to standing or lying to sitting, that your blood pressure drops by over 20 points. That has been seen in concussion. Sometimes people can have, it's not that common. A lot of times people feel lightheaded, but actually, when we check their blood pressure, there is no drop. One thing, that I always tell people is that there are other reasons for that. So, of course, other things need to be investigated. Um, Now, it really depends on what your blood pressure at rest is, because if your blood pressure at rest is low, sometimes just taking some salt tabs to increase it can help. If it's like normal, then you want to be careful, because otherwise, if you do anything like take salt tabs, your blood pressure might go higher. There are physicians who specialize in autonomic dysfunction, so it's maybe sometimes it would be good to get evaluated. The cardiologist can do that. It's rare to see, but there's some neurologists also that are interested in these autonomic dysfunction. So it really depends on where your baseline blood pressure is, and how much of a, you know, sometimes people have these drops, but they're not symptomatic. So we have to take that into consideration.
Great. Okay. Thank you. Well, we are almost at time, and I think we were able to cover most of the questions, which is great. So thank you again for a great presentation, and thanks to everyone for attending and your great questions. Just a reminder, there's going to be a survey coming your way. It just takes a couple of minutes. We always really enjoy getting your feedback. And also, we will be back in 2 weeks on Tuesday, January the 27th, with Dr. Charles Tatter, talking about the treatment of post-concussion symptoms related to screens at work, school, or play. So thanks again, and have a great evening, everyone.